Good afternoon, team. Good afternoon, participants. I welcome you all to this session, and it is our 101 session. We are going to handle infection prevention and control in NICU. Those our participants online, we are going to have a poll, which is our pre-test. We also have your expectations from the session. You also have to contribute. It's going to be an interactive session. So ensure that you mute your volumes, mute your videos as we start the session. But before we continue, let me introduce my team and myself, because I'm with a team of experts from different fields. My name is Chigozi Yusuf, and I am a medical clinical officer, and I work with RFN Medicals and Diagnostic Center in Sierra. Let my expert introduce herself.
Good afternoon, participants. Good afternoon, team. I'm Dr. Bolu Praskovia, SHO, Macquarie University, Pediatrics and Child Health. Thank you.
Thank you so much.
Good afternoon, team. Thank you for joining in. My name is Choncho Gloria. I am a doctor. I am a pediatrician, and I work at Kawempe National Referral Hospital as a pediatrician, but specifically I have interest and I do a lot of infection prevention, quality improvement in the neonatal care unit.
Thank you so much, Dr. Gloria.
Good afternoon. I'm Judith at Chungwide. I work at Malago Specialized Women and Neonatal Hospital. I'm a midwife and a NICU expert. Thank you.
Thank you so much, Dr. Judith. We have our online expert. Please, Dr. Didan, unmute yourself and introduce yourself.
Yes, good afternoon, everyone. I am Dr. Okelo Didan, pediatrician at Busitama University.
Thank you so much, Dr. Didan. Our participants, keep sending your expectation from this session. And I know by the end of this session, you'll be well versed with how we are going to manage or prevent infection in non-neonatal wards and prevent neonates from getting the sepsis majorly. So we expect to receive the pre-test in the next few minutes. And keep on sending your expectations as you answer the pre-tests. This one is helping us know how far we know about infection prevention and control, and it will guide us in our submissions as well. Keep on sending the expectations, you can type in the chat as we continue. Our online participants keep on answering the poll, the pre-test. As you invite your colleagues to log in, because the session has already started. Send links to your colleagues, send links to your friends, so that we can kickstart. Continue answering the pre-test. You keep answering the pre-test. I end the quiz from here. Mr. Alan, you can unmute yourself and give us your expectation from this session.
I would want to learn how we can properly prevent infections in cases where our resources are limited.
Thank you so much. Dr. Betty, unmute yourself and give us the expectations from this session. Dr. Betty? Participants, thank you so much for answering the pre-test. I'm seeing 35 have answered, I've circled option B. Let's continue answering. As Emmanuel Mwesigwa gives us his expectation from this session, Emmanuel? Our pre-test has only 2 minutes remaining, so I encourage you to answer as you invite all your colleagues to attend the session. Send them the link. Emily, you can unmute and give us your expectation. Emily, your expectation, please. Anyone else can raise up the hand and give us his expectation. And our pre-test has ended, so let me welcome Dr. Proskovia to give us the case for today. Dr. Proskovia.
Thank you once again. We are going to dive into our case of this day. It's taken from a neonatal unit of Mulago Specialized Women Hospital. Dr. Agolo Proskovia Adianga, a sexual pediatrics in my final year, pediatrics child and adolescent health, Macquarie University. This case was a CB, the day of flagship was 22 days old, delivered by emergency C-section due to multiple myomas came in active labor. And the gestational age was 27 weeks, corrected gestational age at the time of flagship was 30 weeks plus 1 day. Date of admission was 25th of August 2025, and the child was in referral unit. Presented with high-grade fevers and respiratory distress, which started since birth. This was a 22 days old baby delivered by emergency C-section due to multiple myomas in active labor and 27 weeks of amenorrhea to advanced PG. ABGA score was 8 at 1 minute and 9 at 10 minutes with a back weight of 0.47 kgs. At the time of delivery, the child received surfactant from the referral site and umbilical venous catheter was inserted within a few hours of birth, mainly, I think, because of resuscitation. And the safety concern surrounding the insertion is not well documented. On examination was in a fair general condition, mild color. This examination is on day 22 of life. The child had no diabetes, well hydrated, no dysphagic features, was not in respiratory distress, had equal air entry bilaterally with bronchovesicular breakdowns, no added breakdowns, was saturating at 96% on pre-flow oxygen by nasal cannula. CVS had warm extremities with a cup refill time of less than 2 seconds. Hudson 1 and 2 were had a normal, but there were no added sound. Per abdomen, normal fullness, cord was clear and it was soft. Genitalia were normal with a pattern anal canal. Child was passing stool and urine well. CNS was alert with anterior fontanelle, which was hypotensive, had no motor, no grabs or circumflex, and no moral. This is our follow-up. And on 25th, child came in nursery referral. That was the day of admission. The child was quite stable, but had cyanosis of the left side of her body and a SAS score of 1 out of 10. So we were not in that severe respiratory distress, it was just mild. Investigations that were done on that day, we had a total white cell count of 4.58, absolute neutrophil count of 1.67, HB 14.9, platelets was 161, with a serum reactive protein of 1.91. So our septic markers were normal. The child was started on ampicillin gentamicin, being a preterm, and maybe a low back weight, extremely low back weight child. Then caffeine citrate was continued, and child was put on CPAP and was on nail pause. Had already received surfactant from the referral site, as I earlier mentioned. The following day, 26, that is day 2 of life, and through the NG tube there was aspirate. The aspirate had streaks of fresh blood, though the child was still on FPO. And on day 2, the child had developed respiratory distress with a SAS score of 4 out of 10. That day, no labs were requested or done. CPAP was continued, nil pause, anti-gender was maintained. On the 27th, day 3 of life, child had moderate jaundice. Stomach was still clean. UBC was in situ, and it was okay. No labs was requested. Child was started on EBM, and the distress had somewhat improved on day 3. So we started on EBM, anti-gender was continued, and CPAP. On day 28, that is the 4th day of life, child started spiking high-grade fevers, thick secretions from the mouth. Though jaundice was resolving, child was tachycardic with a heart rate of 178 beats per minute. UBC was still in situ and stomach dry. I didn't put the heart rate at admission. We had a heart rate of around 146, so it was better, but now here we are tachycardic. Lab requested, we had a CBC, or they requested CBC and therapy. Treatment continued as above, EBM was increased. Next slide. Day 29, child vomited once, but passed in stool. Jaundice had resolved. UBC was removed on day 29. And that is the time we realized that child had copious amount of pus that was coming through the UBC catheter from the UBC side. So the part was picked for culture and sensitivity. Antibiotics switched to meropenem and vancomycin. Wanted to cover up MRSA. Child was kept on NPO and oxygen continued on CPAP. On day 7 of life was passing stool. There are no fevers reported that day. EBM was started at 1 ml. Antibiotics continued, meropenem and vancomycin. And then, after 6 days of treatment, child had distended abdomen. It was soft, but later passed through that day, so there was it was because the child had stayed without passing stool. So passed stool and abdomen, the abdominal distension resolved. Chronic US was requested that day, and then it was no more. Treatment was continued as above. Child's EBM had already reached about 5 ml every 2 hours. So day 10, that is on the 10th of September, that is day 11 of antibiotics, of receiving meropenem and vancomycin. Child started spiking high fevers, and then they started asking, I heard, did we get new bugs from the hospital? Something is going wrong. Because initially, the fevers came and we realized that it was coming from the UVC line. So we are questioning what happened. We put so many UVC. Why is it that this one is getting past? Why is it getting infected? Then now, after receiving vancomycin and meropenem and seem to have improved, then day 11 of treatment, we start spiking fevers again. So something went wrong within the NICU. Labs were requested. We had a CRP of 228. I forgot to tell you that when the UVC line was removed and we saw copious amount of pus, CRP that time was 98. It was not that very high, it was 98. And serious CRPs were not done to see resolution on treatment. So CRP that day was 228.19. Total one set counts of 32.7. ANC was 24.96. HB had dropped. Remember, we came from 14. Now we are at 9.8. Platelets had dropped. We were at 161, but now we're at 74. So we're like, I think we picked something else. So we had to pick sample for culture and sensitivity, then switch antibiotics. Obviously, we didn't have to remain on the same antibiotics. We thought of probably we have acquired something new from the hospital. And then also we were thinking, because it's a preterm, we have used high-end antibiotics. So we thought of fungal sepsis. Fluconazole was introduced together with ciprofloxacin. So there was a great improvement. So the day when I was clapping the child, she was very stable. On oxygen nasal fevers were subsiding, and child was tolerating 10 ml of EBM. Next slide. So, given our theme of today, infection prevention and control in NICU, we are raising question of, was aseptic technique of putting UVC followed? That is a question mark. And then what went wrong within the NICU? Because we got 2 different bugs of infection twice. So what really went wrong? Hand washing, was it followed? Hand sanitization, our stethoscopes, our phones, nurses' procedures, we keep removing samples every day. So those are questions of thought. This is where the case ends. Any more questions, comments is welcome.
Thank you so much, Dr. Proskovia, for a wonderful case. Participants online, can raise your hand and ask a question, or you can supplement. I need only 2 participants. Raise up your hand and ask your questions. Or supplement. Yes, Edbert Bagasha.
Yes, please. Thank you very much for the presenter, and thank you for the presentation and the care you provided the baby. I have a question about the culture sensitivity results. You didn't tell us what were the first results you got after the first swab sample was taken off, and then you said them on meropenem vancomycin. Then later, after that, you switched to Cipro, is it fluconazole? I still didn't get what was exactly rationale. If the first medication were sensitive and was sensitive, why wouldn't we continue? Then when you get new results, then we can either switch or something else. I don't know. Just mainly to prevent this antimicrobial resistance. Thank you very much.
Thank you so much, Mr. Bagasha. Another question? Yeah, you can answer.
Okay, thank you so much. Unfortunately, we didn't have culture results, cultural sensitivity. I tried to look into the system, but the preliminary results, which was given us after 48 hours, they were negative. But initially, we saw that there was improvement on vancomycin and meropenem. And child was treated for 11 days on the same antibiotics, and there was no problem. But day 11 of treatment, we started spiking new fever. So we thought, oh, this is a new infection. If it is not a new infection, then we wouldn't have spiked fevers, because we are receiving treatment and it was appropriate for that. Because the reason as to why we got meropenem and the vancomycin was added because of the past, and MRSA responds well to vancomycin. So we had to do that. And when we saw after receiving antibiotics for 11 days, we have new worsening symptoms. We are spiking fevers again, we are getting respiratory distress. So we thought it's something else. And given the experience of Mulago Specialized Women Hospital NICU, most of the bugs there, they're sensitive to Cipro. This is an experience which I can tell you because I've been there for quite some time. They were very sensitive to Cipro, and that's why we introduced Cipro. But also, being a preterm, we are prone to getting fungal infection because our immune system is actually low. And every day we are doing procedures, we are introducing infection, we are doing so many things. So that was the reason, the rationale for adding fluconazole onto the Cipro. Cipro, because we have evidence that most of our bugs which are acquired within the hospital respond to Cipro. They're sensitive to Cipro. That's why we added. It was evidence-based, not just out of the blue. Thank you. But we didn't get any culture result.
Thank you so much, Dr. Proskovia. One more question? Okay. Let's hear from our expert, Dr. Gloria.
Thank you very much, moderator. Thank you very much, Dr. Prosi, for the clinical presentation. This case that the doctor has presented has really showed us what exactly happens in all our neonatal care units. I'm sure most of us who are listening, who are in this session, have really seen babies who are like this. So today, we want to talk about how do we really practice our IPC in our newborn care units. hospital-associated infections, remember, they are also part of the patient safety. And now, right now, actually, the Ministry of Health, we are celebrating Patient Safety Day today in Jinja, all of you, if you know. And the theme for this year is actually safe care for every newborn and child. So this actually directly goes to our patient safety theme for this year. And we are talking about IPC in newborn care unit at this time because we still have newborn infections contributing to mortality of the newborn in Uganda. And we all know that our mortality rate for newborn in Uganda is still high at 22. And we are targeting to reduce it up to less than 12 by 2030. That is just less than 5 years to go. So we need to reduce the infections in newborn care unit. We need to reduce the rate of sepsis or infection that are contributing to mortality. Though different regions have different statistics about newborn infections, some have high, some have low. For example, at Kawempe, we find that around 46% of the babies who are in our newborn care unit usually have infections from anywhere. They can be from labor suit, they can be from referrals, they can be in the unit, but they somehow have newborn infections. You can see values from Bali, but Poto has 15 slightly reduced value, but generally, each one of us has to now know in my unit how many babies have newborn infections. Okay, next. So usually there are factors that generally contribute to our newborn infections. As someone has said, that they expect to know that how should we prevent infections in our setting, in our low research setting. These are our problems usually, overcrowding. We have a lot of babies in the same unit, a lot of mothers are coming in, a lot of caretakers, healthcare workers, students, we are all very many. And also the compliance to hand hygiene practices, compliance to also all IPC practices, and also lack of hand washing facilities in the unit. We have no sanitizers, for example. If you have water, you have no soap on the sink. All these things, you're doing a procedure, inserting a line, but you're not cleaning the hands or the skin. You're putting a UVC, but you don't have sterile equipment, things to use. All these are factors that actually make our babies have infections in our units. Even the ward layout, how have we organized our unit to really make sure that we can prevent infections? The babies who are having sepsis, are we really putting them aside or we are mixing them? Then some babies, mostly babies in our NICUs, they spend long. Like in the case you've seen that we have a baby who has been with us for 20 days, preterms even finished 2 months. So those are the factors associated. So you can see how overcrowding can be in our NICUs. You can go next. So there are almost 7 main elements in IPC. If we are to really prevent infections and control them in our units, we have to wash hands. That is the basic, which we can afford in our low resource setting. We have to wash hands. Then we have to use the personal protective equipment and we use them well. Then respiratory hygiene. If we have cough, if we have flu, put on masks. And also if we have infections, cough and flu, we should really not come to the unit. Or we limit people to come in when they have respiratory infections. Then the SHAPs. Then the injection practices, which should be really safe. Then the cleaning of the equipment, and then the environment. Then also organizing our units. So if we talk about hand hygiene, which should be the most important action that we should really do and we should implement, and it should be really good compliance in our units. We have to use it by either washing hands with soap and water, or we can use sanitizer, which is usually available 70% alcohol-based, and the volume of alcohol that you use should be adequate to make sure that you really do adequate hand hygiene. So we have already talked about it is effective. It is good for research, like our Uganda, and also hands are the main transmission. They usually transmit infections from one area to another. So if all the healthcare workers and the caregivers and any other person who comes to the neonatal care unit who touches the baby or the baby's surrounding, if we all wash hands, there will be significant reduction in the transmission of newborn care infections. So usually the pathogen transmits from one point to another through hands. If you touch, if the patient's skin or the immediate surrounding or surface has the organism, and then you touch, then the germs or the organisms go into your hands, or the healthcare or the caretaker or anyone who's around the baby, then the germs will survive on the hands for some time. When these germs are in the hands for some time, then we suboptimally wash the hands or clean the hands, or even we omit cleaning the hands. Then we shall transfer these organisms to another place, to another baby, to another environment. Then they continue being picked up from, then the cycle continues. So we need to break down the transmission of these organisms through washing hands. These are 5 moments of hand hygiene by the WHO. We all know this. Almost all of us in our newborn care units, we have these charts. They are usually displayed on the sink. However, we don't use them. So we have one. You should wash hands before, actually it is effective washing of hands. Let me add the word effective, before you touch the patient. You also have to wash hands before you do a procedure. You should also wash hands after touching any fluids, anything. Also, you must wash hands after touching the patients and also the surrounding. And we have the pictures that are there. We have all been learning, but I recommend that in our units, this chart, we should always, like quarterly, we make it like a CMA on how to really wash hands. We don't take things for granted. We teach ourselves how do we really wash hands, because we have known that if you do suboptimal washing, the organisms will still remain on the hands and you transfer them from one area to another in the unit. Next. Next. So if you see the chart on your left, you cannot read the words, but remember always to make sure the undernails are cleaned, make sure the palm is cleaned, the inner parts of the fingers is also clean from inside and behind. So this video is going to show us how do we really wash the hands.
Washing hands.
So you realize that in the video, they are showing us how do we make sure that all the aspects, all the areas in the hands are clean. And also you should use clean water. If you don't have a tap, flowing water inside your unit or around, you can always get the tap. You're seeing it in the picture. We have the water. It has been brought and it is powered. We have the soap. We have the container where water should go to, but there is water in the unit. So in our low setting or low setup area, you can't say that, first we don't have a tap, we don't have running water. You can bring the water there in the unit. And also you ensure that if you're to use a sanitizer, you don't have visible soiling of the hands. So sanitizer is an option only you don't have soiled hands. So you have to make sure that there's a continuous access to soap and to water or to the sanitizer. You cannot talk about improving hand hygiene in the newborn care unit when the hand hygiene necessities or what you need to practice hand hygiene is not available. They should be available, they should be accessible, and then you should have, you have to teach people that they should wash hands. People who are responsible for IPC in the newborn care units, this is one of the main jobs you have to do. We do routine assessments and then we educate according to the need. Then we give feedback on the performance, on the compliance of the hand hygiene. So this is one, we talked about having accessible alcohol and water. If you place, this has been found to work in different neonatal care units, but placing alcohol hand rubs in different points, many different points in a unit has increased hand hygiene compliance. For example, for each one baby, as you can see in picture 1, for each 2 incubators or 2 beds or 2 warmers, there is a hand sanitizer. That one has significantly increased hand hygiene compliance in different areas. So you can also, if you don't have it in your unit, you can also put it in place. Then you monitor its whether it has already worked. Yes. Then personal protective equipment. Usually in our setup, we have the gloves, we have the mask, then the protective clothing. So always, if we are putting gloves, gloves should be clean. Sometimes you have gloves, but they are not clean. So gloves should be clean. And when they are put on, they should be removed after the procedure. And when they are removed, they should be disposed of appropriately. And if you're to change from one patient to another, you have to make sure you change the gloves. Then the mask covers the mouth and the nose to avoid these secretions. You can sneeze, you can, so that they don't, or even the organisms from the breath to go into the baby. Then the clothings, usually they are for the mothers, the healthcare workers, but they should be changed. And each mother should use their own clothes. If you're having mothers that are coming in your unit and they're changing clothes, each mother should have theirs. If my baby has sepsis and I have my gown, if I'm coming back, I should put on that same gown, not another mother with a very small baby of 0.7 kilograms right from labor suit. That can reduce the transmission of the infection. So if we have flu and the cough or respiratory infections, we talked about you have to cover the mouth and the nose. You can use tissue, you should use elbow if you sneeze, and make sure you do hand hygiene, either with water and soap or with hand sanitizer. Next. But also we have this other big element of cannula-associated bloodstream infections. Our practices, when we are infusing treatment, we are giving fluids. In the newborn care unit, sometimes you find you're giving 3-hour, 2-hour fluids, which we don't actually encourage. Every 2 hours, you're in someone's vein. So if the cannula has been put, it's already in situ, but you're opening it every 2 hours, there's a high risk of introducing in the infection. But also when we are putting the cannula or the intravenous line, cleaning the skin before we enter. Then also sometimes it's the drugs that we are giving that are already contaminated, as you're seeing on the tray. We mix them, then they spend hours, and then they're not kept clean, then they get contaminated, then the contamination goes into the babies. Then also, you can see in that other picture, the drugs are on top of the file, maybe then they stay there. These pictures, I take them when I'm in different places. So the drugs have been in one place for like 2 hours waiting for another staff on another shift to come and put a cannula. And then when the staff puts, just gives. So those are all not good practices. So here we are showing us how organisms really access the vein or the blood. So you have the skin organisms and you've not cleaned well at the time of inserting the cannula. You push in, they go directly to the bloodstream. Or you have the contaminated catheter. You have the cannula, but it is contaminated. You cleaned your skin, but the cannula is contaminated. Or sometimes you have the contaminated fluid or drug. So you can see that the most common part is usually that skin that we don't clean well. So if in our rural research center, at least we can ensure that we clean the skin before we put these IV lines, it also reduces our transmission of infection in newborn care units. So we also have this hub. When you're going to give, the baby has the cannula already, but you want to give the baby fluids or antibiotics or anything through the vein. You open, we are using our glove or our hands. Our hands have been clean or they are glove, but you open a hub that you have been touching all the time and before you clean it. So we want to first clean that hub, that stopper. We clean it before we touch it. So that when I touch it, my hands will remain clean. That is one of the things that we always almost miss. So you should not contaminate the syringe. You make sure you do not touch the ends of the burette. You keep them covered. Sometimes we hang the fluid and then the ends of the burette are open, organisms just enter, you come back and then continue. So we also can disinfect the rubber stopper, usually on the vial after you have removed one fluid, because I cannot say that we can't use one vial for different babies. But if your vial has been opened, it should be cleaned before you put in a syringe to do another dose. And we should use different needles or syringes for each baby. Sometimes we have a needle, you put a needle in a vial, then you get different syringes to use the same needle in the same vial. That is very wrong. Then we have to make sure we don't combine leftover drugs. You have gentamicin that is in one vial, another in another, then you put them together, that you give it to the next baby. Those are bad practices. Then we should not use infusion sets. If you find this usually happens accidentally, you do not label the baby's burette. Then you find you don't know which one belongs to which baby. Then you put the other baby in another baby. So you transfer infection from one baby to another because you cannot tell which one is whose. So very, very important to label them. So now the equipment in Uganda or in our neonatal care units, we don't have adequate equipment. But how do we use safely the ones we have? There are those which should be single use, but we repeat that we use them anyway because of our resources. So if the equipment is for single use and you can afford to have it single use, please do it single use. I'm saying that because sometimes find we are repeating these nasal prongs, but in the store they are piled up. So check in the store, make sure the amount you have, you use them. So also they found that reusing these nasal prongs or nasal cannulas is one of the leading cause of the hospital-acquired infections in babies. So they should be disinfected very well before they are used. And also we have to disinfect very well according to the protocol. We shall see that. So usually when we are disinfecting equipment, we have steps. All of us, we know these steps, but are we doing them effectively? That's the most important thing. I know you know them, but the most important is, are you doing them well? So before we disinfect, we decontaminate, we clean with clean water. And then we go into soapy water. Then during disinfection or sterilization, if it's a disinfection, you're either using jig or you're using Sidex. Those are the two things we use mostly. Usually, if we're sterilizing, we use autoclaving. But also after disinfection, you're supposed to rinse in clean water, then you dry in a clean place, then you store, and you should store in a clean place. Next. So basically, these are the 7 main things that we do when we're disinfecting this reusable equipment. You get your nasal prongs, your arm bags and masks that you're using on the baby. Put them under running water and disconnect them. Put them in soapy water, then put them in clean water to wash off the soap. And also from there, you dip them in jig or Sidex, whatever you're using. Then from Sidex, you put in clean water. This water should actually be boiled. The fifth water on the 5th step should be boiled, because this is from there you're going to take them for use. Then they should dry. They can air dry. Usually let them air dry. If they are not air drying, you use sterile gauze. Then you take them for storage. And when they are getting stored, they should be covered. So if you're using these decontaminants or the jig or the Sidex, usually these are the 4-bucket system. We all know the 4-bucket system. Then you have the tap that has running water. The buckets are labeled, so each one of the staff in the unit knows where to start from. If the buckets are not labeled, you will think you're starting from which side. Someone can come and start from bucket number 4. So the area should be clean, should be labeled, and the volume of the water inside should be adequate. And each bucket you should know what is where. And that is 5S. You can use 5S to do that. So if you are cleaning at the beginning, you're cleaning, the bucket should be large enough. If you have your equipment, they should all be in the water. That's why we want to use a 10 to 20 liter container. and they should be disconnected. If it is an arm bag and a mask should be separated from the arm bag so that you can easily clean each equipment at a time. Those which can be separated, they should, but there are some which can't be separated, of course, leave them the way they are. Then you should scrub each piece of the equipment. You can use a piece of cloth if there are some particles that are not coming off, clean gauze, or even a small brush. This should be in your unit to intentionally be used. Then we have to scrub all the surfaces of the equipment, as we've said, both inside and outside, to ensure that all the particles are intentionally removed. Then if you're disinfecting, usually when you're cleaning equipment, we said you can disinfect or sterilize it. There are some equipment that are not going to be put in the bucket or to be put in a jig, and they should be autoclaved. Sterilization is better because it destroys all the microorganisms, even the endospores. But disinfection doesn't kill endospores. That's the big difference. However, Sidex can work as a sterilizer. It can sterilize equipment if they stay there for long, as we shall see. But usually autoclaving is for metallic equipment, but the plastics are decontaminated with these other agents. So if you're using chlorine, that is the jig, you prepare, these ones prepare 0.5% chlorine solution, submerge all the equipment inside, make sure at least 2.5 centimeters of the water or of the liquid is seen above the equipment. And then you soak them for, some people say 10 to 20 minutes, but we don't go beyond 30. So averagely soak for 20 minutes. And you should cover the container for those minutes. Do not soak for longer because the equipment will get spoiled. And also you should use high-level disinfection for forceps, and also use the forceps to pick out those equipment if they are in that jig, because it's corrosive and it can affect you. Then the water that you use to disinfect should be boiled, especially at the end. The last bucket I told you, because after cleaning the equipment, you want to take them for storage and for reusing. That water should be clean, boiled. But the first water, it's okay to have it just clean. Then, okay, you can go to next. That is Sidex. It's the difference that it is more toxic, so you have to be careful with it. You need more PPE. You need to cover the eyes and the nose. And for it, you should also change it on a daily basis because the dirt or those other tissues, they also deactivate the solution, though it remains effective for 14 days after being activated. So when you finish disinfection, you want to dry your equipment and store. We said you can wipe them with sterile gauze, and me and you, we know in our local setup, in our NICUs, sterile gauze is also not very common, but air drying is also equally good. However, sometimes you have the equipment, you don't have much time to wait for it to air dry. You can just wipe it, but with a sterile gauze, you putting on sterile gloves, preferably you wearing also even a mask. Then also we'll assemble the equipment before we store them so that they are able to be used next time. We have to check their functionality. We don't want to disassemble. Then you keep an equipment that is not functioning. Then we make sure when we are storing them, they are covered. So these are just examples of the equipment that we take when we are in our NICUs, different places. These are poor practices, of course, you can see. They are open, they are mixed up, they are stored, and this is not really good. So each one of us has to look in their unit. How are we storing our equipment? How are we disinfecting them? Are they all functional? Next. So the four bucket system. So we say that the liquid should be 2.5 centimeters above the equipment, but you see how we do it sometimes. So all these things are the ones which are actually causing us to have high infection rates in our units. If the disinfection process is like that, you're seeing in that picture one, how many buckets now are these ones? Is it a 7-bucket system? But you don't know when I come, where should I start from? So someone can come and drop and you don't know where you are. So that is not good. And equipment will not be clean and they will transmit infections. So you also have to make sure you clean the radiant warmers, clean in detail those incubators, as you can see. So there are some equipment that don't need to be taken into disinfection process with alcohol, with a jig, with Sidex, or autoclaving, like thermometer. These are one of the most common equipment that actually transmit our infection. Thermometer, use the thermometer from one place to another. Please clean it, wipe it with alcohol, and very well, put it there, let it be ready for using another baby. Stethoscopes, the doctors, the nurses, stethoscope, the pulse oximeter, the transcutaneous bilirubinometers, the laryngoscopes, and the fiber optic blades. Sometimes some blades can be autoclaved, but some of them, which are fiber optic, they have that light inside, you don't autoclave it. So always, if you have the blades, you have to look at their manufacturer's advice on cleaning. Then there are these wires, these like, for example, a thermometer which is on the radiant warmer, you have to wipe it. Okay, and these other wires which are for plugging into the socket, all those things for the equipment we use. So we want to have the environment cleaned very well. There should be a cleaning checklist so that each area is on that checklist, and every day you look at it and you're like, have we cleaned in this place? Who's responsible for cleaning today? Everyone should be knowing that this and this area should be cleaned this and this often, and then we check that we have done the action. Then the cleaning equipment should be made in a way that you don't mix them. The cleaning equipment for the toilet, for the neonatal care unit. Sometimes if you have this preterm section, you may even say this small, like our baby was 0.7 kilograms. That is very small. You don't want to clean the equipment of that, or the item of that area with the one that you clean in the sepsis corner. You can decide to really separate them. So now that I've talked about the cleaning of the equipment, we talked about hand washing and all that, we also want to see how do we really organize the unit so that we prevent infection, and also how do we do waste management in the unit. And Judith is going to take us through that. Thank you very much.
Thank you so much, Dr. Gloria, for a wonderful presentation. You keep writing your questions in the chat. As our sister Judith gives us the role of midwives and nurses in infection prevention and control in NICU. Sister Judith, you're welcome.
Thank you. Thank you very much, our moderator. Thank you, Dr. Choncho, for the wonderful presentation. So I will pick it up from where Dr. Choncho has stopped. Please, can you display the slide, please? Thank you. Okay, so I'm going to look at waste management. And that in our NICU, we generate waste. So it is very important for us to understand how we do waste generation. And after you've generated your waste, it is very important for you to know that you need to segregate it. And after you've segregated it, it is very important for us to know how to transport it. Most people transport the waste when it is open. We need to know that we have to close and then transport. And then definitely we are going to look at the storage and then the disposal process. Next slide. Okay, so in waste segregation, every hospital really has a protocol. This has been sung. So in segregation, you pick the wastes and then you segregate them according to the levels of infection, or how infectious the wastes are. So that should be bins and bin liners, and these bin liners should be colored so that you are able to identify which bin liner is going to contain which level of infection. And then the waste bins should really be consistently supplied in their designated places and according to the workflow, so that you do not have to move looking for a bin from one point and you go dripping down blood or any other wastes. So waste bins should be emptied before they fill up. And this should be really the role of a nurse, to ensure that you work with the waste management team, that all these things are emptied on time. Okay, we used to have so many bins, but we recently have a new guideline. And so we have the 3 bins. So in waste management, we really want to clarify that on the new waste management guidelines, we have the red bins. And in the red bins, we are putting the highly infectious wastes, the soiled, are all put in that red bin. And then we have the black bin where we put non-infectious wastes. And then we have the brown bin where we put our pharmaceuticals. So we realize that in the pharmaceuticals, when you are segregating the pharmaceutical bottles or vials or whatever, you don't dip in the glass, they're called vials. Are they vials? That of ampicillin, is it a vial or an ampule? Dr. Pros, it is a vial. So the ampules, yes, the last ampule, like the one of gentamicin. So those that are really able to break down or cause an accident, you dip them in a sharp box. You don't put it together with the pharmaceuticals, the rest of the pharmaceuticals. So I think that is important to note. Next slide, please. Yeah, and then, we talked about waste segregation and, so you can imagine these are the practices that we have in different places. It's so bad that the nurse was caught up in the picture, probably she was from dropping there something. This is part of what we go through in our facilities, but these are wrong practices. Like we have said, that the wastes, once they are collected, segregated in their different bins, in their respective bins, then they should not fill up to that level. We should have at least a third of it, and then you call people responsible for taking them so that they can have a way of closing up the bin liners, and then they can safely carry them. And when you look down on your right, on that brown bin, so you can imagine it is a brown bin with a yellow bin liner. So that is a wrong practice in the first place. And then you realize we have a sharp box that is very full, and it is our practice. You just come and feel like you cannot go to make a next safety box. So you want to squeeze, you want to shake it so that your sharp can also fit in there. And eventually you end up dumping them down. And so that can cause accident, and that can also spread infections in our NICUs. So for the sharps, it is very important for us not to recap. I think this has been sung, and so I repeat, after giving an injection, for example, an IM injection, you're not supposed to recap. And even when you are establishing a line, you're supposed to have a sharp box by your side, that immediately you have established a line, you pick out your needle and straight away drop it into the sharp box. Don't put it besides the bed. Don't put it in the gloves. Don't put it elsewhere. Please direct it into the sharp box so that we avoid accidents. And so we are supposed to replace the sharp containers when they are 2/3 full. Don't compete with them getting full to the maximum. Next slide, please. Okay. So as we proceed with the safety, let me continue talking about the procedures a little bit. Very important that as you are performing a procedure, as a nurse, you're supposed to carry a tray on a trolley, and your tray should really be well marked. You have a galley pot that has cotton, you have maybe if you don't have the already packed alcohol swabs, you have alcohol by your side, and then a safety box must be a must to move along with your tray or your trolley, so that when you are establishing when you establish a line or when you are giving an injection, you don't compromise putting down or elsewhere your used syringe or needle. Well, so let me go to unit organization. We all know that when units are starting, the nurses do a lot to organize and rearrange the units. So it is our role that as you are establishing SOPs of your units, the visitors should have a policy. Not everyone should come in a NICU, not at any time. And when they are coming in, your protocol should be very clear. Anyone that has fevers, anyone that has running nose, anyone that has cough, anyone that has a skin rash really should be stopped from coming into the NICU unless otherwise. And if they must, then you should really protect them and give them protective GIs. And then we usually change street clothes and the outside shoes before entering NICU. And this is really, I can call it cosmetic though. Research shows it doesn't have any effect, but because we are in a muddy region, we don't want to have our NICUs with mud and everything. We know it is not food that spreads the infection, it is our hands. Yeah, but because this is a practice we have as a country, please ensure that when you come into the unit, even you as a staff, you're not supposed to move to the NICU with your street clothes. You have to change them and then you wear the clothes that are fit to be put on when you are going into the NICU. So as you organize your units, you're supposed to have a hand washing facility before you enter the unit. If you are able to have a sink at the entrance, please, you can put there a sanitizer that at least you wash your hands or hand rub your hands before you enter the unit. And then like Dr. Chichoncho was presenting, you saw one of the slides that had so many people, and it was quite amazing. These so many people were students, nurses, and that is what I saw. Very few of them are outside people. So we have to stop overcrowding, limit the visitors, limit the students, because you have the capacity to say, in my unit, I can accommodate 10 per day. And so you can handle that if it is your policy. So this is a time when we are supposed to have SOPs happening in our facilities that everyone knows. But besides that, there is also overcrowding of patients. For example, in this month of September is an interesting month where most NICUs are sharing incubators and baby cots and radiant warmers. Quite interesting. So for such case, when you have nowhere to admit babies but rather to have them share the beds, we encourage the nurses to learn how to do nests. You make a nest and the nest will contain a baby in one position. The baby will not move, will not put the hand to the other friend, they are contained in one position. So it is very important for us to isolate infants with the infectious disease. Whenever we have such babies, please let us isolate them. And then important for us to have 5S in our units. And 5S has been sung. It is a song that is sung but not implemented. So it is high time that we learn how to sort. As nurses and midwives that work in a NICU, it is really a shame for us to have very many things in NICU when they are not even working. So sort out what you don't want and take it away. Give it to people that can use, set them, then shine and make a standard and then maintain your standard. Okay, so part of what we have talked about is that there should be a space, at least 1 to 3 meters of space between each bed, each incubator or a baby cot or something. But when you come to our facilities, you find some facilities have really space, but they do not consider this. They just put babies anyhow, they put cots anyhow. But like we have seen, it is very important for us to have the space between each bed. A space will help a nurse, a doctor, and the caregiver to move around when they are doing their procedures. Actually, this space can also allow you to put an extra chair if you are going to do, for example, kangaroo mother care. You have a space where you can put the chairs, and then you also have time and you have space for you to interact with the baby without rubbing each other. And then if possible, it is very important for us to separate the preterm babies from the term babies so that we can limit the issues of infection. Okay, so this is part of our common practice. When you reach at the entrance, please change the street shoes and move into the NICU shoes. Then we have gowns. We have gowns that are put for patients, and then there is also a room for the staffs to change before they enter into the NICU. So this is how you should be organizing your NICU as you come into the NICU to work. Next slide. Okay, so we felt that we needed to chip in the way we dilute JIC, part of what we do in our day-to-day work. So we often get supply of JIC and we get different solutions. And most people just keep with the old thinking that the ratio is 1 to 11 or 1 to 9 or 1 to 10. No, you have to understand the concentration they are giving you, they are supplying you, and then you calculate and get the parts that you're supposed to give. So for example, if I'm given the concentration of JIC 3.85, I'm going to get my solution. For me to get the total parts of water that I need to add into this JIC or chlorine, I will get the percentage of chlorine which have been given, which is a 3.8, for example, 3.85. I will divide it by the concentration 0.5, then I will subtract by 1. So the answer that I will get will be equivalent to the parts that I need to add for water. I know that mathematics used to be very hard, but this is now an example. I almost used sticks to elaborate it more. So this is what I'm talking about. So in case you are supplied with the concentration of 3.85%, this is how you calculate, and then you subtract by 1 and you get a total of 7.7, then you subtract by 1, get 6.7. So 6.7, you correct 7 because 7 is above 5, and that will round up to 7. So that means that if I'm mixing my jig, I'll get 1 part of water, of jig, sorry, and then I will add 7 parts of water, and then I stir well, and then I use my jig for decontamination. So this is just a simple calculation of how we can get the percentages. So when you are supplied with chlorine, please just look at the percentage that you have so that you can calculate very well the parts of water. This is when you have the powder or the tablet. So the calculation is the same. You do 0.5 over the percentage of the chloride that you have, you multiply by 1,000, and whatever you get will be the parts of water that you will add. Thank you. Next slide. Okay, so we want to say that IPC is just a behavior, and it is a key behavior that every facility, every unit should really uphold. So we are saying, please wash and wash and wash and wash. And when you wash, we will have a very good hand hygiene. Please observe your environment cleanliness. Make sure it is clean. Make sure that the medical equipment processing is in place and they are clean. Then health waste, please let it be part of us. We know these days we have people who come and take tenders and we just leave it for them. Remind them, and if possible, have sessions with them, have sessions with your cleaners so that they know how to mix these things, they know how to mix the jig, they know how to mix the soap, they know how to clean the floor and any other surfaces, and then the wastes. So I want to say that surely for a baby in a NICU and the mother, their journey is basically in your hands. So if you observe all the IPC measures, these mothers will be happy when you're handing over the babies to them. If you do not observe, then we will be like a case that we have seen. Baby comes with cyanosis and then gets spas along the way and then gets further infection, very bad. So it is in your hands. So let us clean our hands so that the journey of the mothers and the babies are safe. Okay, so of course there are some key points to remember, Remember that the microorganisms do not move for sure. It is us who helps them move from one point to another point. And we have seen that really hand hygiene is the most effective single measure for preventing infection, and proper waste segregation and disposal enhances IPC in our facilities. So in conclusion, therefore, we want to say that IPC measures is a collective effort. Everyone, a doctor, a nurse, a lab, a biomedic, a cleaner, a security person, it is a collective measure. So let us embrace it and we work together. And then let us have IPC protocols in place in our units and follow them. And let's also have IPC champions in facilities that have worked towards achieving IPC. They have established champions that when you come and you've forgotten and you just want to touch the baby, they just say, hello, your hands are not clean. And politely, that changes the practice. So let's get the champions to help us adhere to IPC practices. Thank you.
Thank you so much, Sister Judith, for a wonderful presentation. I hope by now most of your expectations have been acquired. Hope everything you expected has been delivered. But I will allow you ask questions where you've not understood. And for anyone with any supplement on what has been discussed, you can also raise up your hand and we'll give you a chance to supplement. Thank you so much. As we raise up our hands or type our questions in the chat, I'll ask Dr. Didan to give us the most outstanding question in our chat so that can be responded to by the experts. Dr. Didan?
Thank you. Yes, I think most of the questions asked have been addressed, but the most commonly asked question I've seen so far is how do we prepare 70% alcohol? I try to explain, but I think someone needs more explanation to it. I'm going to type it. And then we also have how long the reconstituted jig should stay after you've reconstituted, and we have mentioned 24 hours. Yeah, the rest I think are okay. Yes.
Thank you so much, Dr. Didan. Our experts, if you can respond to that question.
I thank you very much. I want to talk about the preparation of 70% alcohol. The person who is good at describing how to prepare 70% alcohol is actually the pharmacy person. Eh? So usually the pharmacy of the unit usually is good at helping us in that. So I am not sure about that. However, if we have a pharmacist on the call, they can also help us answer that. However, but we usually have it really prepared and we pick it from our pharmacy. But also the other alcohols, sometimes they're supplied when they're already made, so we just use. But the pharmacist is good at answering that, sure.
Thank you so much.
Maybe just to add on that, I've replied. I put some formula on the chat, and maybe the person may need to know some additional things that when you get the volume that is required, the V1, you will subtract it. For example, if you are looking at 1 liter, you subtract it from 1 liter, and that deficit is what you will use for dilution to give you the 70% alcohol. But I'll put the formula in there. I will continue. Maybe I will give an example so that whoever is interested can use it. Thank you.
Thank you so much, Dr. Didan. Sister Dr. Proskovia, please give us a take-home message.
Wow. Okay, it has been a very wonderful presentation. I want to emulate everyone for their participation. And then also our presenters. I really think that we need to get comments, because why do we still have these practices when we are seeing things every day? That is the question. We come from different facilities. I think there is need for us to listen to challenges that is faced, since we still have some time, that is faced from like few facilities. You said those pictures that have been taken, they're actually demoralizing, because I think ministry go every day, like in different facilities, trying to see and the correct practice should be put into place. And then secondly, every facility should take it as a mandate to identify where they have their leaking taps, and then they close it. So where is our gap? Why are we not adhering to the IPC protocols in our NICU? And at what points, where do we get infection? I think there is need to identify the source of infection in our NICU, and that should be addressed accordingly. Because we cannot say, okay, can say IPC, but there is something that is coming. You find the oxygen prongs, the filters are not changed. I think that is one thing that people always forget. You find that the oxygen concentrator, we're using the sensor filters every day. Those who goes on vent, we're not changing so many things. The tubes are reused, and yet they're supposed to be disposable. Then the disinfection time is not well adhered to. Nobody is there to follow the SOPs that should be there, that should be followed. So let us identify where we have issues, That is, identify the leaking tabs and then close the leaking tabs if you are to achieve the IPC. Thank you very much. But we need to get comments from different facilities. Their challenges. Why do we still have what has been displayed there? Because these are from different facilities. Not like you can give us from your area, your NICU. Why is there overcrowding? Can't you identify a space and make it more spacious? Where is the problem? Thank you very much.
Thank you so much, Dr. Proskovia. Sister Judith, what is your take-home message?
Yeah, I just want to say that IPC is just a discipline. And once we discipline ourselves and take it in as part of what we are supposed to do on a daily basis, then we will definitely achieve. It is very important for us to understand that as we practice the wrong practices, we carry these things home to our children. So it is very important for us to know that the bad practices we do, they will eventually inflict on us. You just come with your cloth, for example, and start working, you are going to carry these bags home for your children. And, see children having flu every time, they have cough this day, they have an infection that is not responding to treatment. So it is just a discipline that, when I am entering into a NICU, I have to enter into a pantry and wash hands. Just a discipline. Wash your hands, put on your shoes, and move inside. Change your clothes, and then enter into the NICU and work. So what I can say is that actually it is a discipline that we need to instill in ourselves, and we will achieve. Thank you.
Thank you so much, Sister Judith. Dr. Gloria, I have a question, and it goes. Recently, we were informed of a 5-bucket system being recommended. Bucket 1, clean water. Bucket 2, soapy water. Bucket 3, clean water. Bucket 4, JIC, or high-level disinfectant. Bucket 5, clean water, then air dry. Any updates about that?
Thank you very much for the question. Actually, this 4-bucket system, we are considering that if you don't have running water as tap, you can put another bucket as another water as a bucket. So at the end of it, it is 4 sites. It is 5 sites, but we are saying 4 buckets because most people can have running water in their sluice room. So if you don't have water in the sluice room, you can have that tap water that is flowing as a bucket. So it is actually, it has not changed, but it has been put, that's how it is. So you can have 5 buckets, but you have the water. If you have the running water, you may not put a bucket. So it is the same. There's no difference. And we said the main reason for having that first water, the first bucket, is to remove those obvious soiled things, the obvious blood, the obvious tissue, removing them. So that remains the same role. So you can put it in the bucket or it can be flowing. So it is okay.
Okay, thank you so much, Dr. Gloria. But before you hand over the microphone to me, give us your take-home message.
The take-home, you guys, my colleagues, my frontline healthcare workers who are always in NICU, who move hands from one baby to another, one environment to another. We need to have a habit or a culture, an infection prevention culture in our practices. If you don't wash hands, you should basically feel uncomfortable. If I don't wash hands, I feel uncomfortable. I feel like I'm so dirty and I can't move on. So you need to have that feeling in your head. But that one is I'm going to task the IPC focal persons in neonatal care units, because each unit, at least the Ministry of Health has done good work, that each unit, each hospital has quality improvement committee and has work improvement teams, and each unit has that team. So we need to functionize our teams. The IPC team, who is in neonatal care unit, make sure you can set an indicator for always, like quarterly. Quarterly is very far. Monthly, talk about hand hygiene compliance, collect data, observe, analyze, give feedback. Just like how we have to have quality improvement culture, let's also have the IPC culture, because IPC is part of the quality improvement. So, and we usually have teams, everyone is in there. So let's give it more time Let's have our data, our own unit assessments, give ourselves feedback, check what have we done. Can you really identify which practices you have done and put them together and share them? That's what Dr. Prosi is asking. For you, what do you have to share with us? Can you tell us the challenges you have or what you have done really to do better? You know, so my take home is that the IPC focal persons, the IPC team of the hospital, we need to go to the neonatal care unit, have the indicator that we are going to use to follow up whether we are improving or not, and what we can do, gather together the good practices, be able to share them when they are working. Thank you.
Thank you so much, Dr. Gloria, for that take-home message. Our participants, you can be responding to the post-test as Dr. Didan gives us his closing remarks.
Thank you so much, everyone who has attended this session and your active participation and question sessions. Yes, IPC is a broad subject, and I would say that it also faces challenges that sometimes may be beyond an individual. It's kind of a collaborative activities that help in maintenance of IPC. For example, we also know that limited PPEs and supplies sometimes end up affecting. So whoever is in the stores and is making requisitions should make sure that they get enough so that we do not have to break that chain. We also know that our systems, we have overcrowding, understaffing itself. So you find that one medical personnel is attending to 10 neonates, and sometimes they may not implement proper IPC. We also have challenges of water and sanitation. We've seen that water is actually a very important aspect in making sure that we clean our items, we keep hygiene and clean where we stay or dwell. And most importantly, inadequate training and compliance monitoring is one of the challenges. In most hospitals, you realize that they sublease the cleaning services to companies, but these companies do not invest in training their workers. So you find that the cleaner is putting on their gloves, they are picking rubbish after, and they're mixing the rubbish, the contagious rubbish to the non-contagious. They are mixing it just in order to carry it, to move along with in the buckets that they are using. You know, they don't want to come back. They forget that there is a very big difference. It's very important to be cautious. And then from there, they are touching walls, they're touching doors. So that's very important. So it's not only, it starts with us as the health workers, but also we help the systems around us. As they are bringing new cleaners on your hospital, please, on your ward, make sure that you take them through IPC and they should know why they do certain things. Thank you.
Thank you so much, Dr. Didan. There is one more question here. The tap water is not safe, probably contaminated. Why after using jig, then rinse with tap water again, yet it's contaminated? Dr. Gloria?
Thank you for the question. After rinsing with jig, we do not go back to tap water. We got a bucket that has boiled water. We are talking about boiled because it is clean. If you have distilled water, in fact, distilled we have. Actually, I think it's harder to boil. Thank you, midwife. You use distilled water. The last water has to be distilled, not tap water, because your equipment needs to remain disinfected.
Okay, thank you so much. Thank you so much, Dr. Gloria. Our dear participants, thank you so much for attending this session. It has been so wonderful. Now, I would request only one of you to tell us what he or she has learned from this session as we close. One of you should raise up the hand and and we hear from I'm seeing a hand. Esther Muzaki, tell us what you've learned from this session.
Good afternoon, presenters. Thank you for the wonderful presentation. Okay, for me, what I've learned is about using distilled water in the last bucket, because I didn't know about this, and we've been using tap water. Using distilled or boiled water, I didn't know about this, so maybe I'll take an initiative to change this, because we're using tap water, then after we air dry. Thank you.
Esther, seeing Ivan. Ivan, you can tell us what you've learned from today's session.
Thank you very much. For me, what I've learned, it is the new guidelines with regard to waste disposal. Because previously we have been using the 4-bin. Because I've been seeing now nowhere the yellow bin appearing, and it has been really confusing me, but it's only today that I've learned actually the red bin is now containing what was recently before contained by the yellow bin prior. Thank you very much.
Thank you so much, Ivan, for your submission. Any challenges first? Anyone with a challenge first? Okay. Keep on answering the post-test, dear participants. Yes, Collins, you can unmute and give us your challenge or what you've learned from today's session. Collins? Colin. Colin, tell us what you've learned from this session. We are not hearing you, Colin. Our participants, let's unmute our videos. Let us unmute our videos. Let us unmute our videos, our dear participants. Let's unmute our videos, our participants.